Hello and welcome to part 3 of this webinar series, the upper GI tract and peptic ulcer disease. My name is Moyo Olukoga. I'm a final year medical student at Lancaster Medical School. This is brought to you by the Medics.Academy virtual elective. I had a really good experience and I'd recommend you sign up. You can find out more information using the link in the description box below. This is a 3-part webinar series, and this video is part 3, peptic ulcer disease. If you haven't already, click on the link in the description box below to look at part 1 and part 2 of this video. So, before we begin, just a bit of history for you. This is a picture of Dr. Barry J. Marshall. He believed peptic ulcer disease was caused by the bacteria Helicobacter pylori. He was so convinced he drank a culture of H. pylori. He fell ill, developing acute gastritis. At the time, there wasn't a link found. It wasn't until many years later that H. pylori was linked to peptic ulcer disease. And gratefully, he received a Nobel Peace Prize for his work. And I believe that's what you call commitment to the job. Peptic ulcer disease. This is defined as ulceration of the gastric or duodenal mucosa. It occurs following a breach of the muscularis mucosa layer because of damage to the mucosa, disruption to mucosal protective factors, or excess secretion of hydrochloric acid. Aetiology. Helicobacter pylori, or simply known as H. pylori, when a person is infected with it, this can lead to damage to their mucosa, so they are susceptible to peptic ulcer disease. NSAID use disrupts the mucosal protective factors through the inhibition of the COX-1 enzyme. Normally, COX-1 leads to the production of prostaglandins. These prostaglandins allow protective mucus and bicarbonate to be produced. However, when people use NSAIDs, COX-1 is inhibited. Therefore, prostaglandins aren't made. Therefore, the protective factors such as mucus and bicarbonate make the mucosa more susceptible to damage. Stress has also been linked to peptic ulcer disease. Quite a rare etiological cause is Zollinger-Ellison syndrome. This is hypersecretion of hydrochloric acid from a neuroendocrine tumor. Also, there are other medications which make people more susceptible to peptic ulcer disease. This includes SSRIs, bisphosphonates, and steroids. Clinical presentation. To learn a bit more about peptic ulcer disease, let's work through a case history together. So here's a picture of Stuart. He is a 45-year-old male who presents to his GP with indigestion and epigastric pain. Despite using Gaviscon, the discomfort from the indigestion has not been relieved. What else would you like to ask him? You can pause the video here and jot down what you'd want to ask him in your history. Before you take an amazing history, Stuart remembers and he says the pain is worse when he eats. This is a common exam question. Do you know if it is typical of A, a gastric peptic ulcer, or B, a duodenal peptic ulcer? If not, don't worry, let's find out. Clinical presentation. So, you've taken an amazing history. These are some of the key things you'd want to focus on. You want to explore the pain a bit more. Ask them to describe it. Most people describe peptic ulcer disease as a dull pain. Ask about the timing of the pain to see if it's nocturnal. Does it stop them from sleeping or does it wake them up at night? You want to know how the pain is with food. Is it worse with food? Because that's typical of a gastric ulcer. Or is it relieved by food? Because that's typical of a duodenal ulcer. Find out about other associated symptoms, such as nausea and vomiting, any change in bowel habits, any weight loss, or feeling bloated. Some people may offer information such as triggers. They may say alcohol makes it worse, or caffeine, or specific foods, typically spicy foods. Finally, We know that certain medications are linked to the development of peptic ulcer disease, so make sure you take a thorough medication history, looking specifically for NSAIDs, SSRIs, bisphosphonates, and steroids. Red flags. You want to look for any red flags in your history and examination because there could be signs of blood loss from a perforation, and you'd want to treat the patient for this as soon as possible. So look for anemia. Have they been feeling more fatigued? Do their nails have any changes? Are they more pale than usual? Ask them if they've had any blood in their vomits. This is known as hematemesis and is typically a coffee-stained ground appearance. Ask them about their stools. Have they passed any dark, bloody, tarry, offensive stools? This is known as melena. Finally, if they're bleeding, you want to assess for signs of shock. Have they been feeling more weak than usual or lightheaded? It's very important that you ask the patients this because it can guide the rest of your management. So, back to our MCQ. Stuart said the pain is worse when he eats. We now know this is typical of A, a gastric peptic ulcer, while a duodenal peptic ulcer would have pain relieved by food. Let's look at some investigations. So we said H. pylori is a cause of peptic ulcer disease. So you'd want to investigate if Stuart has this. One way we can do this is through a urea breath test or a stool antigen test. This just helps us know whether H. pylori is present. You'd want to do endoscopy. This helps us look at the mucosa of the stomach and the duodenum. It's done through a camera tube, which is inserted into the patient's upper GI tract. And if you have any suspicions that the patient is bleeding, you'd want to do a full blood count, a group and save, and a cross match because you want to prepare to stabilize the patient. So Stuart does a stool antigen test and it's positive for H. pylori. Given this information, do you know what your treatment plan would be? A, would you give him a PPI? B, would you give him amoxicillin? C, would you give him a PPI, clarithromycin, and nitrofurantoin? Or D, would you give him a PPI, clarithromycin, and amoxicillin? Management. So, first of all, you want to know whether the patient is bleeding or not, because this determines what you will do. If the patient is actively bleeding, you'd want to do an endoscopy as soon as possible to locate the source of the bleed. You'd want to arrange for a blood transfusion so the patient is stabilized, and then you'd want to prescribe them proton pump inhibitors. If you watched part 1 of this video, we looked at how hydrochloric acid is produced, and proton pump inhibitors can target this. A typical proton pump inhibitor is omeprazole. If the patient is not bleeding, you'd want to treat them according to whether they had H. pylori or not. So patients who don't have H. pylori, you can start them on a PPI until their ulcer is healed, and you can confirm this by endoscopy in 6 to 8 weeks after the prescribed PPI. If they do have H. pylori, you'd want them to undergo an eradication therapy. So once more, you'd commence them on a PPI, you'd give them clarithromycin and amoxicillin. This is to get rid of the H. pylori. If a patient has a penicillin allergy, then you give them metronidazole instead of amoxicillin. So, based on this information, how would we treat Stuart, who had a positive H. pylori test? If you selected D, PPI, clarithromycin, and amoxicillin, that's correct. This brings us to the end of part 3. So to summarize, peptic ulcer disease is a breach in the muscularis mucosa. Peptic ulcer disease is typically caused by H. pylori, NSAID use, and stress. Investigations include testing for H. pylori and endoscopy. Proton pump inhibitors are important in the management of peptic ulcers. Thank you for listening. If you have any questions, please email me at simplymedics@gmail.com or at simplymedics on Twitter and Instagram. If you want to see some of the lectures my colleagues are producing, make sure you click on any of the other videos in this channel. Make sure you subscribe and like the Medics.Academy YouTube channel so you can keep up to date with the latest videos. Finally, if you're a medical student, make sure you sign up to the free SDocs program. A link is in the description box below. Thank you.